Good morning, доброе утро, все мои друзья в России. Я очень скучаю в России. Это уже больше чем 10 месяцев, что я не был там. Я очень страдаю. Я люблю Россию. Но я надеюсь, что это проблема сейчас мир. Скоро мы будем ехать опять видеть, что новое. So I will speak in English, and this we are talking about new system. It's called DisFix, and this is completely different system that we know. This system is like a new idea. Okay, it's not I usually many times I don't represent it as a surgery, but I represent it as a procedure. We have somebody who translated over there?
Yes, Professor, I'm translating it, don't worry.
Okay, so I continue.
Yes, sure.
Okay, so what is the idea? What is new about DisFix? First of all, the whole procedure takes about 5 to 10 minutes. This is completely different way of thinking. The patients come in, it's performed under local anesthesia and sedation. It's not general anesthesia. The patient comes in, and after 10 minutes, he goes back and rests for 1 or 2 hours at the ward, and after 1 or 2 hours, he goes home. This is not a regular, normal surgery. It's a big, huge advantage for the patients, and the patients like it. Another very, very important thing, everything is performed without a knife. We put a needle, a working cannula inside the disc. We see everything through image intensifier, so we can see it very good. And we evacuate the disc, then we pass some radio frequency, 2 types of radio frequency. One to shrink the nucleus, and the second one is to shrink the annulus itself. And this is a huge advantage. And thirdly, we can look inside and see what we have done, so we can follow up it by scope that we put inside with the apparatus itself. So actually, this is a surgery that includes in one surgery 3 different techniques. And it's been proved that when we add 3 or some different technique, we optimize the result of the surgery. So if, for example, only one thing, only with nucleoplasty, for example, we can have like 60-70% of success rate. I think here with the DisFix, we can have about 80% of success rate. And the big difference is that we do everything without a knife and actually without risk. Why it's without risk? Because we go with the needle from the side, we don't go through the canal. When we go like surgery through the canal, we always have some risk to damage one of the nerves, to end up with even paralysis or some adhesions. Here we don't have it. Actually, after the surgery, the whole area of the spinal canal remain actually virgin, no touch to those neural tissue, which is a great advantage. So, in a brief, the DisFix include 2 or 3 stages. The first one is here on the left. We go in, we shall see later the technique itself. We go in with the working cannula, and then through this working cannula, we put a pituitary. Actually, we remove parts of disc outside, and we see them, and we can put them in our hand and we can gather them. Sometimes what I do, I put them in a sponge, and at the end of the procedure, I can give it to the patient, so he can feel, he can see himself the disc that was taken out, like open surgery, no difference. This has some advantages, maybe psychological, so the patients can see it and can actually verify what was taken out. This is the first stage. The second stage is here. We put a straight or almost straight cannula. This is big cannula that transfers the radio frequency to shrink the nucleus. Okay, it's a different type of radio frequency. It's 1.7 megahertz, but in this going on, we use this type of radio frequency in elongated burst energy, and that's why we shrink the nucleus. Then this is the third phase. We shrink the annulus itself, because as we do in nucleoplasty, we also only shrink the little bit of the nucleus itself. And here we shrink also the annulus, which has a great importance. Also, I can tell you that with the Disfix, the amount of the regular frequency, it's 10 times more if we compare it to the regular nucleoplasty. Also, it's very important that during the whole procedure, there will be irrigation the whole time, because as we know, the radio frequency works better in fluid environment. So we have, what are the treatments that are available in the market of back pain or in the market of herniated disc? So we have two big groups. We have the conservative treatment, as we see on the left, and we have the operative or surgery group on the right side. With the conservative treatment, we all know about it. We know that it includes some kind of medicine, of anti-inflammatory, like Voltaren, like painkillers, like paracetamol, Arcoxia. We have so many, but unfortunately, we know already, but there is no one medicine or not one tablet or injection in the world that cures. It helps the pain. It helps the symptoms. But we are trying not to talk only about the symptom, but to cure the reason of the pain, to bring back the herniation of the disc. And we can do it, as you'll see soon, without open surgery. More of a conservative treatment, we can do lots of types. There are so many types of physiotherapy: Maitland, McKenzie, extension, traction, so many. But unfortunately, none of them, and we're all over the world, there have been no proof that each of them is better than nothing, meaning it's not better than the natural history, and each of them is not better than the other. So if they ask us, what kind of physiotherapy? I tell them what kind that I like, but it means nothing. We don't know, we don't have any proof. So as a surgeons, we cannot give them advice that was proven that it helps or not. Other conservative treatment, as we know, we can use injection, we can use epidural, we can use heat, we can use cool. Both of them, we don't know what it is. We can tell the patients, hey, try heat. And they say, well, I already tried, it doesn't help. So we tell them, okay, try cool, to cool it. So it's like a joke. We don't know the results, but whatever the patients like, we are not against it. Then about the alternative medicine, we have so many people that make a living from this kind of alternative medicine, acupuncture, whatever. I'm not against nothing, but we have no proof that it works, any effect on the disc. That's why we cannot give advice as doctors, as surgeons. We are not allowed to give advice that was not proven. And so this is what I tell my patients: you could do whatever you want, whatever helps you, I'm for it, I'm not against. But the idea of not doing anything is also, we know the natural history, that like if we wait a long time, like 70 or 80% of the problems get better without doing nothing. So sometimes we have to wait and everything will be okay. Also, let me talk about the idea of rest, bed rest. We know for many years they say that it works. Why don't you rest in bed? But we know that it does not. On the contrary, always I recommend my patients to go to work and to come back to their normal life if they can, of course. And it helps them from the psychology point of view, instead of lying down in bed, looking at the walls and thinking about the walls. This is much better that there will be, it helps to be occupied with their works. Now about the other group is the group of surgery. We have many types of surgery: open, laminectomy, discectomy, fusion. Again, many types of surgery. But of course, we keep it as the last resource. Also, the patients are afraid of open surgery, especially with my experience in Russia. They're very afraid. They don't want to go through open surgery, whatever the reason is. So what we can do in this case, we can suggest, instead of surgery, same idea, same results, very similar results as open surgery. We can give them another option, is the disc fix. The disc fix, as you see, is the middle group. We have one group, conservative, we have the operative, and we have the middle group, which is not small. This is very big group. We all know it. We all know that we tried for a long time conservative, no improvement. The patient don't want to go to surgery either. They cannot, because the anesthesiologist does not allow them to do the surgery. So we can suggest to all those patients a new method, which is not a surgery. It's a procedure that does cure the disc itself. It treats the reason. It treats the prичина, not the symptoms. That's why usually the patients want it. It's without any risk, because we are not going through the canal. There is no way that we can cause any damage to the spine. Nobody can be paralyzed. So it's not going to be worse. The only possible, very seldom complication is infection, 1 out of 1,000. And we know that in open surgery, only this infection rate is 30 times more. This actually, I tell my patients, the bigger this, that maybe it will not help them. It's about 20% that this procedure will not help. 80% will. Very important to tell the patients. And the only risk actually is not neural damage, but infection. And if we have infection, we should treat it with antibiotic, unlike open surgery. Okay. So this is the bipolar waveforms. This is the radio frequency. It's completely different than the other tools that we know, like the nucleoplasty. Here, there are 2 types. One, it's called the turbo, to shrink the nucleus. And this is a big and very strong, 10 times stronger than the other one. And the other type is bipolar hemo, that shrinks the annulus. Those are completely different types of energy. The first one is elongated energy burst, and the second one is short burst of energy. And this gives different type of results. So again, we start with this is actually the nucleus ablation after evacuating the disc with we shall see later, with pituitary. We evacuate as much as we can. And usually we talk about 1 cc, 1 gram of a nucleus, which is enough. and we can also bend our pituitary to take the disc from the place we want. Then we use the nucleus ablation, the straight part. Here is the straight part of this procedure. We put it inside the nucleus. We pass this. We should see we do it like 6 times at the front and the posterior part of the nucleus. And then we introduce the second one to make the annulus modulation, to shrink the annulus. We'll see, for example, here, the size of the annulus, and we see the size of the annulus after the annulus modulation, which use the other type of radio frequency. And we made some experiments on human disc, and we see that we can shrink the size of the annulus by 30%, which is a lot. And when we do it, and actually what happens when we shrink the size of the annulus, we made the epidural space larger, and there is more place for the nerves, and we relieve the pressure over the nerve root, over the dura. So this gap between the conservative and the surgery group, there is a big gap because many patients don't want it, they're afraid, and the doctors don't want it very much. So, and there is a reason why they don't want it, because the results of open surgery can be very good, as we know, but sometimes they are not very good, and sometimes we have quite a lot of complication. For example, we know that the amount of patients that need to go for re-operation, second operation, is big, is very big. And if we do it with disc fix, there is no problem to repeat the disc fix because this is not open surgery. If we have to repeat open surgery, we all know that this is a very big, complicated surgery, and sometimes the results, as we know, as you can see here from this walk and spine, that the results of the surgery, second surgery, is only 60% of good result, which is not good. So usually the patients we are talking about between 10 to 20% of the patients that need to have second reoperation, which is very, very not good idea. Also, we know that the plasma decompression, the radial frequency, actually can heal the cartilage itself, and it reduces the injured disc for the cytokinin expression, so the patients have less of a pain after the procedure. So again, actually, this procedure includes 3 different techniques. One is the mechanical evacuation of the disc, of the nucleus, like in open surgery. That's exactly what we do in open surgery. We use pituitary, we take out as much as we can. The second one is nucleus ablation using the radio frequency with the special strong, very strong electrode. And the third one is annulus modulation, which means the narrowing of the annulus itself. They are completely different. Radio frequency, we see that for the nucleus, we use the turbo, as we see it on the pedal, which works with elongated burst of energy. And this is for the annulus itself, different, and the results are different. This is some experience with the probe that we see that we really shrink the annulus, and we shrink the nucleus by a big size. And we are talking about for the nucleus that we can shrink it by about 1 gram, between 0.08 and 1.8. And this is a lot of nucleus only by the radio frequency, even without the mechanical evacuation of the disc. So here, as you can see, this is only with the disc fix with the radio frequency. we see the amount of shrinkage of the size of the nucleus. And here is some work in order to verify the safety of the procedure. We can see that the temperature inside the disc, inside the nucleus, and around in the annulus itself, it's about the maximum that we can arouse is like 30, 32, 35 in the posterior part of the nucleus and of the annulus. So actually, there is no risk from getting any heating damage to our dura and so forth. So this is the shrinkage of the annulus and of the nucleus on laboratory disc, and this is the effect of the heating. And this also, there are some sites histologically after radio frequency, we see some healing and remodeling of ingrowing of the fibroblasts that invade back to the damaged disc, and there is healing of the disc itself. And we can see it with MRI. Before we see like a black disc, and after a year, we can start to see again healing of the disc itself. We can see a white disc again, like the discs that are normal disc. So how we use it? We use it with local anesthesia. We use a little bit of sedation, depends on the situation, on the patient. If they want only local, we can use it local, but usually they want some kind of sedation. It's not general anesthesia. We do it I do it myself on side position. If you prefer to do it on patients lying on their belly, it's okay. Depends what you are used to do, to go from the side, from the postolateral approach. It's called the foramen approach. Of course, everything is with fluoroscopy guide approach. The needle is placed in the triangle safe zone of Campbell that we all know about it. And then we continue, we put inside over the K-wire, we put a very small needle, and then we put over the wire, we put a walking cannula, which is very small. Then we use the punch to remove mechanically disc as much as this as we can from the nucleus. Then we put the first part of the radio frequency straight part to shrink the annulus, then the second part to shrink the annulus, first the nucleus, then the annulus. If we want to look and to have verification of what we did, we can use the endoscope and see what we did, how much of a shrinkage we got. The candidates for this fix are actually symptomatic patients for contained disc, protrusion, and also extrusion disc, and of course DDD patients. And I will tell you why we can use also for extrusion disc, because we can, at the first part, we put the punch and we push the extrusion part back inside the disc itself, and then we pull it out. So we can use it for contain, extrusion, protrusion. This for sequestration, it's not in good indication, so we don't use it. Secondly, of course, the patients have to go through at least 6 weeks of conservative treatment, whatever it is. And of course, we have to have CT or MRI that are consistent with the signs of the patients, like SLR, radiating pain, and the neurological signs should be concordant with the finding of the CT or MRI. Exclusion criteria are patients with fracture, infection, of course, evidence of cauda equina, progressive neurological. If they have severe spinal stenosis, it's not a good idea. Let me tell you that I am now enlarged my indication. I use it for the patients with neurological injury. Actually, I did it on my wife. She was in severe pain, and she had on MRI, not big disc, but she developed, in 2 days, she developed a drop foot. So I decided to use the disc fix instead. I did it myself. I would not do open surgery on her, but I did this, and she was recovered in 2 days. And thanks God, up to now, this is already 5 years ago, there is no problem. The risk, of course, discitis, very, very seldom. Injury, it's very, very unusually. Actually, if you start to do it under local anesthesia, the patient can give you some sign that you are near a disc, so you can change the position, and then you can put the second and third part. Dural leakage, I didn't have, never. Of course, it can be some kind of osteochondritis, meaning pain, because of the heating maybe. And of course, not all of them are having perfect result. The results are not 100%, but they're at 80%. So we have to tell them that always, if it doesn't work, we can either repeat it or make open surgery. I will go quickly. This is some literature about the world. This is Dr. Hellinger in Germany. He was the first in the world to show this technique and to have, this was his results. This is a vase for the pain after the procedure. And this is our results in Israel that I myself, I did up to now almost 4,000 cases. This is the first results that I got. And the inclusion criteria are the same: axial pain, radicular pain, both, and the VAS should be between, the visual analysis score for pain should be between 5 and 10, and the neurological examination under either normal or pathological. Again, we can use the disc fix for patients with neural injury. Of course, we need the CT and the MRI, contain disc, as we said before, 1 or 2 levels. And this is some demographic. We use conservative treatment, which were not very effective. Then we recheck the patient 1 month and 1 year after the procedure. And infection rate, this is the first 1,000 cases. We didn't have any infection. Now with the 4,000 cases already, I have 3 cases for infection that we treated them with antibiotic IV. No bleeding and no neural injury, as I told you before. So we did this, the first 300, we did prospective analysis. We took demographic, CT, MRI. We checked on all of them, the VAS for pain, the function by Oswald-3, SF12 satisfaction, and neurological examination. And I will go directly to results of those 300 first patients. The result for radicular pain got back to 50% or more in the first months, and later in the year the same. The results for motion limitation, again, we had very good result. This is the Oswald-3, again, a very good result for the function. Patients, like 84 patients, we asked them if they would recommend this procedure to their family or friends. They say yes, 84%, and this is the treatment satisfaction. 2 upper group, 61 and 28%, together 89% of good results, and this is very good results, much better than the natural history. Some of them get better immediately, and some of them get better after 1 or 2 months. After 2 months, if they don't get better, this is it. We can declare it as a failure. So even we measured the SLR improvement after the procedure. We saw quite a big improvement after the procedure. And this is the neurological examination that got better after the procedure. So with this first 300 cases, we see that the total reoperation was 2%, which is better than the open surgery, because we know with open surgery, we have like 10% of reoperation. And if we have to reoperate on those patients, it's completely different. It's much more different. So it's very safe procedure, high efficacy. So this is it. We can see a video, short video, and you can ask me question, please. This is male, 38 years old. This is the big disc that we can see on the CT. And this is, again, the CT. You see what a big extrusion of the disc we had at L4-5 level. And we decided to use the disc to, and this is the video. You will see here. If it's boring, you can stop me. And this is the video. We put the patient, as you see, on the side. The patient is lying down. This is our image intensifier. We see very good the disc itself. I don't know if you hear my talk on the video, but this is, first of all, this is the technique. We put like just for examination, we want to be exactly parallel to the disc, and we want to put our needle exactly at the middle of the disc. This is very important, as we can see here. Usually, if it is 4-5, we take like between 10 and 12 centimeters from the midline. I just use my fingers because each of my finger is 2 centimeters from the midline. This is the entry point. Then we make a very small incision, just 3 millimeters of incision. And we introduce this in the incision. And then we introduce the needle. Then through the needle, we put inside the disc the K-wire, then the working cannula. So this is how we put the needle inside. We, of course, we follow all the time at the image intensifier where we are. And this is actually, and we can ask the patient at this time whether it hurts the leg or not. And we can feel at this type, actually, we can feel that we are sitting on the annulus, okay? And this time we can move the image intensifier to the AP view, okay? And then we can see at the AP view that we are exactly located in between the inner part and the outer part of the pedicle of the upper and the lower vertebra. It means that we are in the right place. If our needle, we see that at the AP, it's inside the line that connects the inner pedicle, we can imagine that we are inside the dura. So it's not a good idea. So we have to change the placement. Okay, but we see everything. Usually I use now, because I have a lot of experience, I use usually lateral view because I feel with my finger that I'm sitting just at the posterior line, and I can feel with my finger the annulus. So I'm sure that I'm there. Okay? So guys, maybe I think we are running out of time, because I want to give you time for questions. So if you want, we can continue to see the video for another 7 minutes, or to stop it here, and there you will see Dr. Hasatorian, who does it even better from a live surgery. Valerie, what do you think? To stop or to continue to hear some question or to continue the video? Or what we can do is to hear your question and you can watch the video itself at the same time. Valerie, tell me what you think.
Reuven, on behalf of the whole audience, I would like to thank you for your great lecture, for your great presentation. And I think as to our schedule, we're very close to the time of live surgery, but still I would like to ask several questions,
Please.
Which we've got through our special form. So if you're okay, I will read these questions for you.
Let's read them and then meanwhile they can watch the video. Go ahead. Questions?
Okay, just a second.
Please.
So there's a question from Dr. Maxim from Moscow. He has two questions in one. First part, is it possible to use Discefix at cervical level? How often you do it and what are the results? And then addition, what is the practical sense in the use of for the use of endoscope in Discefix procedures? Do you use endoscope for Discefix procedure, which you do?
No, okay. I'll start for the second one about endoscopy. This is for myself. I've done it on few, but there is no practical sense. The only sense, if somebody want to get a lot of experience to start learning how to use endoscope, this is endoscope for stupid, for people with no, so it's a good idea to use for all the cases, just to use it. There are some places, some countries that if you use it, you can reimburse, you can take more money for the procedure because this is endoscopic, you can reimburse more money. But really, from the practical point of view, you don't have to use it. Now about the cervical spine, yes, there is this fix for the cervical. It's a little different. It's much smaller, of course, and we use a smaller, very, very small and gentle tube, but still, and we have also a special technique and a special similar one, but a special wand that it's different, and this is for another workshop, but the answer is yes, and I've used it on many cervical.
So there is next question. Okay, can we switch to the next question, Reuven?
Yes, please.
So the next question from Dr. Galperin from Moscow.
Okay.
Is there any danger for development of discitis when Discefix is used? And what you do to decrease risk for discitis? And in addition, do you use discography for diagnostic purposes?
Okay. Usually it is recommended to use discography, but I myself don't use it because of some kind of complication. We are talking about 0.5 rate of infection rate with discogram, so I prefer not to use it. If I look at it in the MRI, from my point of view, it's enough. Then about to reduce the discitis. We have two types of discitis, as we know. We have one type is the infection, and this is, of course, what I use. I use antibiotic IV, and also I use intradiscal irrigation with saline with antibiotic. This is very, very important. We have to remember always that we must irrigate all the time. The radio frequency works better in environment of fluid. That's why we irrigate, and I use some antibiotics. For the aseptic discitis, which can be a problem, which can cause a lot of pain to the patients. At the beginning, I had quite few patients, they had a lot of them. Now I use intradiscal steroids in all of the patients. So when I finish the procedure, I put in the disc itself depomedrol, and it can reduce the pain, the amount of pain. And also I use epidural on all of the patients at the same time at the end of the procedure.
Okay, thank you. And one more question. There's a question from Michael, Dr. Michael from Moscow. So do you do local anesthesia and if patient is under sedation, how patient is able to answer your question?
Well, what I do, I can start. Only for the first part that I use this very, very small needle, I think it's a good idea just to use local anesthesia, okay? But I use only local anesthesia at the skin. I don't go inside because I don't want to anesthetize the nerve root. So he can tell me whether he has shooting pain to the leg. And if this, I have to change a little bit the procedure. As long as it feels okay, only pain, a small pain in the area of the spine itself, I can transfer and put one cannula which is bigger.
Sorry, Reuven, could you repeat the last last part, because I didn't hear it. There was some problem with this connection.
Yes, I have Skype problem as well. I don't see you, but anyhow, I am repeating that we start the local anesthesia only for the first part, for the needle, to be sure that we are not hitting the nerve root. Always there is a risk about the foramen. It's not a must, but I feel better if the patients tell me that he doesn't have irradiating pain from hitting or being very near the nerve root. Then I can sedate him. He feels nothing because I'm okay.